Hi, everybody. I'm Michael Carisse, welcoming you to Raise the Line from Elsevier, an ongoing exploration about how to improve health and healthcare. In the United States, nearly 70% of people say they want to die at home, yet the majority still die in medical settings, often after receiving care that may not align with their goals and values. Closing that gap between preference and reality is at the heart of the work being done by EndWell, a nonprofit dedicated to transforming how we think about, plan for, and experience the end of life. I'm joined now by Dr. Shoshana Ungerleider, an internal medicine physician who founded EndWell nearly 10 years ago, with the ultimate goal of creating a future where, as she puts it, ending well becomes a measure of living well. Through an annual symposium and year-round initiatives, the organization brings together clinicians, patients, caregivers, and innovators to drive cultural change around dying and caregiving. In addition to her work with EndWell, Dr. Ungerleider regularly appears as a medical expert on CNN, MSNBC, and CBS News. She hosts the podcast Before We Go and the TED Health podcast, and she's been involved with 2 Academy Award-nominated Netflix documentaries on end of life. And thank you so much for being with us today.
Oh, my goodness. Thank you for having me.
We always like to start with getting some background on our guests. So I want to know what first got you interested in a career in healthcare and particularly internal medicine.
Yeah. Well, it was definitely not a straight path for me. I probably had 10 different majors in college. I was really exploring a lot of different interests, everything from fine arts to geology. I ultimately ended up with a marine science degree. I didn't land on medicine until well after I graduated, which I think in hindsight gave me a much broader perspective on, I think, people and the world. And then when I finally came across medicine, it was really years after I'd graduated, and it felt like all of my interests could kind of come together. And I think I was especially drawn to internal medicine because I felt like every patient was like a puzzle. You're sort of listening carefully, you're gathering pieces, you're trying to understand the full picture medically, certainly interpersonally and emotionally, socially, all those things. And I think that process of curiosity and connection is what kept it really engaging and exciting for me. And I love that I get to be a lifelong learner. I guess you'd do that in every field of medicine, but especially with internal medicine and having to know so much about taking care of adults. I'm constantly reading, and that makes it really meaningful for me.
And then in terms of end of life, were you having, lots of conversations with patients or seeing, end of life situations that troubled you, or why did you start going in that direction?
Yeah, it began early on in my residency. And honestly, looking back, it was a series of moments that really stayed with me. I realized that in medical school, we spent all those years learning how to diagnose, to treat, to intervene and save lives, which is wonderful. And then almost as an afterthought, there was a brief introduction to what happens when medicine can't fix things. And it, again, looking back, felt completely out of proportion to how important serious illness and the end of life as a phase of life actually is. And again, during residency, I started seeing that up close. I remember being in the hospital at night. I one time was called to pronounce a patient who had died. And I was an intern. I didn't know what that meant. I had to Google it. And I walked into a room filled with a lovely family, and they'd been there for days and days with mom. And instead of kind of walking into chaos or panic, which is what I had imagined it would be, there was this sense of peace. And they'd talked about what their mom had wanted. She was comfortable. She was actually receiving comfort care in the hospital. And that was the first time I think I really understood what a good death could look like. And then the juxtaposition of many other moments that were much, much harder, taking care of very sick people in the ICU, surrounded by machines and undergoing really aggressive interventions. And honestly, with very little chance of recovery. And I think often without a clear understanding of what they would have wanted. We didn't really have those kinds of conversations often enough. And those experiences were really jarring for me. And they made me realize that sometimes in our effort to do everything, I think we can lose sight of what actually matters to the person in front of us. And the fact that we need to be having those conversations early and often, especially with seriously ill people. And I think that's when I really started questioning the system.
When you hear people discuss this issue, there's a lot of talk about the culture of medicine in the United States, particularly, doctors are not trained to think about stopping treatment. There is always another thing to do. And it's uncomfortable for them to say, hey, there's probably nothing else we're going to do at this point that's going to make a difference, because they don't want to give up on it.
Michael, there's always more we can do, and we'll get into that, because when we say there's nothing more we can do, there's always more we can do to take care of people. It may just not be focused on cure.
Well, that's it. That's what I'm talking about, a curative path. And there's also a sense that the patient doesn't want to give up, quote unquote, on the family, because they're interested in trying another thing. So there's a lot, obviously, in there to react to. But what are your thoughts generally on these cultural issues?
Yeah, I mean, I think that it's a complicated issue, right? I think there's this misalignment in what most people say they want at the end of life when we ask them, and that's to be comfortable, to have a dignified end, surrounded by people that they love, sometimes at home, although not always. But what they often experience, and far too often from my perspective, is something much more medicalized. It's in a hospital, maybe in an ICU, aggressive interventions, a lot of intensity that may not actually align with their values. And I say may because some people really do want to have, everything done to keep them alive, even if they fully understand that means they may suffer and be in pain at the end of their lives. And that's what they want. And we are poised to do that, right? And that's great. That's fine. But I do think that's not what most people want when you ask them. And I think what drives this disconnect is a mixture of culture and systems design. And culturally, we don't talk about death early or openly enough. So when a crisis hits, families are making decisions, loved ones are there without really knowing what their loved one would have wanted. And in those moments, the default, of course, is do everything, even if no one fully understands what that actually looks like. And I think on the medical side, we're getting better at this, but we train clinicians to treat and to fix, but not nearly as much to guide people through thinking about their own goals and values around death and dying. And I think structurally, certainly in medicine, we're incentivized to do more. The system tends to reimburse procedures, hospitalizations, interventions, right, more readily than it does time spent having really thoughtful conversations about goals or supporting someone at home through hospice. Even well-intentioned care can drift toward doing rather than listening and asking thoughtful questions. And I think there's also this issue of time, right? These are complex, emotional conversations that really require, ideally, trust and rapport, but our healthcare system doesn't consistently create space for them. So the gap isn't that people want the wrong things, it's that our culture and our incentives aren't aligned with helping those wishes actually happen at the end of life.
So how do you align the incentives?
I think there's a few shifts that would probably make a profound difference. I think first we have to normalize earlier ongoing conversations about what matters most to people, and not just in their final days or during a crisis. And I think that means asking not just, what are we treating, but what are you hoping for? What are you worried about? How do you define quality of life? If time is short, which, by the way, it is for all of us in a sense, how do you want to spend your time? What trade-offs are you willing to make for a chance to get better? And then revisiting that over time as illness evolves. And I think when those preferences are clear, care tends to align much more naturally. It doesn't mean you'll automatically get exactly what you want, but I think you're much closer to a place where there's, again, this understanding between patients and families and care providers. And I think this is where early integration of palliative care is so important. We have lots of strong evidence that when palliative care is introduced earlier, at the time of a serious illness diagnosis, not just at the end, patients have better quality of life, they have better mood, patients have, a clear understanding of what lies ahead for them. And then certainly the families and other loved ones feel more supported. And I think it creates space for exactly these kinds of longitudinal and trust-based conversations, I think, rather than compressing them into a crisis. And then I do think we need to realign incentives in the healthcare system so that taking time and listening and goal setting are valued, not maybe as much as procedures, but valued more than they are now. Right now, it's much easier to order another intervention, right, than to sit down for a 30-minute or hour-long conversation about prognosis and priorities. So I think expanding access to palliative care and then certainly hospice earlier would help shift care toward what people actually want. And then third and finally, I think we have to change how we train clinicians. I think being much more comfortable with death and dying, better communication skills training, understanding how to care for someone when cure isn't possible should be more core competencies. We're getting better at this. We really, really are. Since I trained, things have moved, significantly. But I think at the end of the day, aligning care with someone's values isn't about doing less. It's about doing what matters most for that person in that moment.
That's a wonderful way to say that. And so then enters Endwell into this picture.
Yeah.
Give us the backstory there and some sense of the initiatives you take to try to create the change that you're talking about.
Well, Endwell really grew out of this tension that I'm mentioning, and I finished residency and I couldn't ignore it. I think in my clinical work, I was witnessing so many patients suffer in the ICU at the end of their lives, often in ways that certainly didn't reflect what they would have chosen if we had asked them questions or prepared them better. And there was this repeated experience of highly technical, well-intentioned care that really felt disconnected from the human experience. And that left me with a lot of moral distress. I now see it that way. And at the same time, right when I had finished training, I had the opportunity to get involved with executive producing 2 Netflix documentaries focused on end of life, Extremis and Endgame. And I think seeing how deeply those stories resonated and both were nominated for Academy Awards, made something very clear to me. And that is that there is a real appetite for honest and human storytelling about death and dying, right? People are willing to engage with this, even though it's hard. And I think that was a turning point. It highlighted for me that if we want to change how people experience the end of life, we certainly can't rely on medicine alone. We need interdisciplinary solutions. We need clinicians, certainly, but also folks from the media and designers and policymakers and spiritual leaders and caregivers and patients, communities all kind of working together to shift how we think about and approach this stage of life and hopefully come up with solutions, right, to make these experiences less hard for people. So Endwell was sort of created as a space, as a conference to bring these worlds together. And then from there, the work has really expanded into thinking more intentionally about culture as a lever for change. And one example of that is looking at how end of life is portrayed on television. And I early on felt like those narratives really shape expectations in a really powerful way, often more than clinical encounters do, certainly. So many patients would come to me. I'd meet them for the first time in the ER if I was admitting them, and I would ask about, code status. And they would say, oh, well, I know what CPR is. I saw it on Grey's Anatomy. And of course I want that. I mean, those people just hop out of bed 10 minutes later and they're fine. And we know that's not true, right? Survival, after aggressive resuscitation efforts, rarely results in folks leaving the hospital. And if they do, they're in a very different state. And so encouraging Hollywood to portray these storylines about illness and end of life more accurately in a more nuanced ways, not just the dramatic resuscitations or, acute traumatic death, which we know is not the norm for most people. It does happen, of course, but I think we're starting to see glimpses of that in certain shows where there's emotional and sort of ethical depths to these moments. So Endwell got to do some of that research and then work with some of the TV shows, kind of working on that. And so I think it's about recognizing that the end of life is not just a medical event. It's part of the human experience that's shaped by our culture and our systems and our stories and our relationships. And I think if we want that experience to be better, we have to work across all of those dimensions and not just within the walls of a hospital or a clinic.
So you used the great phrase there, culture as a lever for change, and television, obviously, that you've referenced. We recently had Mel Herbert on, a veteran ER physician who is a consultant and writer on The Pit and was on ER back in the 90s. And that show has made a real impact in that it's taken medical accuracy more seriously than a lot of other shows in that genre, and also allowed, people to see the kinds of deep conversations that need to have in those medical environments. So talk about the work you've done with TV shows, including The Pit.
Yeah, well, I have to just say I'm a huge fan of The Pit. I think they've done a phenomenal job. And sort of in these last several years, we've been doing research looking at how end-of-life narratives in television actually affect people. And the findings are striking. We published a couple white papers about this. I think what we've seen is that when people watch thoughtful and emotionally grounded storylines about illness and dying, they're significantly more likely to start conversations with their loved ones, to seek out information and even take concrete steps like documenting their wishes or helping family members plan. So it isn't just driving education and awareness, it's actually shifting behavior. And I think what's powerful is that storytelling seems to lower the barrier that so often exists around those conversations. So part of what Endwell has done has been helping to build that bridge between healthcare and media. And we're seeing shows that, we've had the opportunity to, help shape small parts of the storyline, like A Million Little Things when that was on TV, The Gentle Art of Swedish Death Cleaning, or more recently, as you're mentioning with The Pit, they've written in really beautiful story arcs around goals of care conversations, around having, a death doula in an ER, which was like kind of shocking to me. And I have to believe that the work that we did with the USC Norman Lear Center, sort of doing this research and creating tip sheets for writers specifically on death doulas, helped to inform some of that content. So, it's been exciting to see that really come to life in that show. And I think when you change how we talk about death, you can begin to change how we experience it. At least that's my goal with spending the time to do this work.
So for people in our audience interested in having this kind of conversation with an elder or a parent, what's some of the language that you can give them to start a conversation and have it head in the right direction?
Yeah. Oh, well, it depends. And so you're specifically asking for family members or for clinicians to be doing this?
Well, these are parallel conversations, really, you've been talking about. It does reside with the clinician-patient relationship, but also the family relationship. So what I had in mind was the family relationship, but you can deal with either.
I guess I would say it's never too early to start having conversations with the people you love about what matters most to you. I think it can actually be a beautiful way to get to know your family or your chosen family better by asking things like, I watched an episode of The Pit and they were talking about this thing about, what your wishes might be if you were to be sick and who you'd want to speak for you if you weren't able to speak for yourself. And gosh, hope that doesn't happen anytime soon. But certainly the more kind of open and prepared we are, I think the more likely we're to get care that we really want and that we understand. And so, thinking about these questions, just first reflecting for yourself, what matters most to me in my life. Again, I love this question of like, if time is short, how would I want to spend that time? And it's funny, like I'm somebody who, if I'm sick, I actually want to be in the hospital. I feel comfortable there. It's
Right.
some physicians really, I mean, even though we kind of know what happens, I think, that wouldn't be the end of the world if I spent my final days in the hospital. So it's really not about being prescriptive about what you want and imposing that on somebody else. It's really just having open, honest conversations. And I think the big thing, from my perspective, is less about creating, written formal documents, although those are important. It's really about having these conversations and then thinking about, who do I trust in my life? Who do I want in my life to speak for me if I can't speak for myself? And then talking to that person or set of people and having these kinds of conversations. Again, it's kind of never too early to do that stuff.
Speaking of how we talk about it, part of your goal is to infuse wonder, joy, and hope into these conversations about end of life. So tell us more about how to do that and what that looks like.
Yeah, I think one of the biggest misconceptions is that if we talk about death really honestly, we somehow drain life of meaning, right? And I think in my view, the opposite is really true. When we make space for mortality, we often become much clearer in our own lives about what really matters, who matters to us, how we want to spend our time. So when we talk about bringing wonder and joy and hope into this space, it's not about denial or about sugarcoating. These conversations are hard, but it's about recognizing that even near the end of life, there can still be opportunities for beauty and for love and connection and even humor and creativity and ritual. I think, hope may no longer be in that situation hope for cure, but it can be hope for being comfortable, for presence. For some people, it's reconciliation, right? I think wonder can come from witnessing how deeply human people are connected in these moments, right? And I think certainly, in my own experience with taking care of my dad, who died of pancreatic cancer a couple of years ago, we certainly found joy in music and in storytelling. And those things are not separate from good end of life care. They're really, really part of it.
No, well said. As we wrap up here, we have an audience of learners, medical students, nursing students, and so forth, and early career professionals. So I'm wondering what message you want to leave them with about approaching these issues in their healthcare careers.
Well, I think I've talked a lot about, how I think thinking personally and then talking about end of life is so important throughout your own life and then through your own career. So I guess my advice would be to folks, in medicine or thinking about pursuing a career is, don't lose sight of why you came into medicine in the first place. Because there's so many things that are going to be really, really hard about training, and the system itself is not set up to support you. I think, again, early on, many of us are drawn to medicine because we want to save lives and solve problems and make a difference. And I think all of that is so good and so important. But I think over time, you learn that healing is bigger than curing. And some of the most important work that you'll ever do is not fixing, but witnessing and guiding and staying present with patients. So I will also say, try to build the career that feels true to your values, even if it's not conventional. We need excellent clinicians, but we also need people, I think, working at the intersection of medicine and education now more than ever, of policy for sure, of public health and storytelling and design and advocacy. All those things are so critical. And this is a moment that calls for both skill and imagination. So I think there's an opportunity to help build a more humane system if we encourage people to think about that.
Well, that's wonderful food for thought for our audience and a great perspective for them to have in mind as they go forward. With that, I want to thank you so much for being with us today. Really appreciate your time.
Thank you for having me. This was a wonderful conversation.
I'm Michael Carisse. Thanks for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelines podcast.